Okay, you guys can see my screen?
Yes.
Yes.
All right, just trying to make sure I'm recording. So this class isn't really so much to go over the material, although we will go over some material. It's also to teach you guys how to study and hopefully to get you guys together so that you can study appropriately and learn from each other. Just going to move our pictures off the screen because I'm recording and I, for one, don't want mine on there. Okay. So one of the things that you have to do first is go through the chapter. You have to skim the chapter. Look at what those objectives are and try to look for those through the chapter as you're skimming it. Now, I'll skim through the chapter. I'll read it as I'm skimming through it. I'm not reading it word for word because you're not going to be able to comprehend all that information. But as I'm skimming through it, I'm looking for things that are associated with those objectives that are important, and I'm highlighting those things. Once you do that process, then put the book away. Go back to it the next day and go back through it again and write your notes, and or later that day, write your notes that you've highlighted. And then you're going to have to go back again, put it away, go back again, and then now take those notes and condense them into things like flashcards. Some of you can do this without notes, but it's really hard to do it with the amount of material you're trying to learn in a short period of time without them. And the notes are going to lock it into your brain long-term if you do it in this process, little short segments. And then within 24 hours, you want to go back, review, and rewrite those notes. That will lock it in long-term. Now, what that does for me is it sinks it in my brain. So now when I open up, you guys can see this question on the screen?
Yeah.
All right, this is a question right from chapter 17 about newborn transitioning, because part of the newborn transitioning process is what? What happens when the baby comes out of utero into the world? What's the difference between being inside and outside in those first few minutes?
They're on their own. Like they start to breathe on their own. They're not dependent on the mother.
Okay. What else? What's one of the biggest shocks coming out of there besides the fact that they're going to take their first breath?
Body temperature change.
Yeah, that temperature change, right? Because it's so warm inside. Now they're going to come out into this cold air. They're wet. Okay. And that wetness is going to cause heat loss because it's going to cause evaporation and things like that from the skin. So you got to be aware of this, and if you read like all the nursing management for every disease process that you're reading through in chapter 17, it always goes back to one thing: thermoregulation, thermoregulation, thermoregulation. Got to keep the baby warm because we want to prevent something called cold stress, right? So one thing you're going to want to know from these chapters is how is heat loss happening? What's the different types of heat loss and how does it happen? So when I look at a question like this, the first thing that I'm going to look at, this only has one question in it really, so I can't go to the very bottom, but I always look at the last statement in the question because that's really what the author wants to know usually. So it says, which action is most effective in preventing heat loss? Before I would even try to answer this question, I would think of what types of way is heat lost by evaporation. And we just talked about one of them, right? Which is what? Think about science class. What is evaporation? What is it?
So would it be drying it?
Okay, without trying to answer the question, stop trying to answer the question. Let's learn the information. So what I'm trying to get you to do is before you even answer the question, what kind of brainstorming could you do in your own mind about this?
It's because the baby is wet and the moisture takes away the heat loss from the body.
Okay. What else? What other ways could the baby lose heat during this process? Would it be evaporation if they lost heat those way? Or would it be something else? What is conduction?
When they're placed on a colder surface.
Okay, so they're put on like a scale or on a cold mattress, and we don't put anything between them and that cold item. Their body quickly loses heat from that contact. What is convection?
The air flowing over them.
Okay, like a convection oven. So they get that draft over them.
Yes.
And what is radiation?
Is that like a lamp?
So they can get radiated heat from things like a lamp, right? Like a heat lamp. How could they lose it?
Can they lose it by sweating?
Well, sweating would be what? Come on, nurse, talk to me. Sweating
The
would be
shivering,
what?
the shivering when they come out in the cold, the shivering, the body shaking.
So radiation is going to be like when we put them to a cold window or near a cold wall. All right, so we keep the cribs and the isolates away from the outside walls, cold windows, air conditioners. So all stuff you would want to know. Me, myself, I would have, sorry, people are always blowing up my phone when I'm trying to do session. Me, myself, I would, know all these different ways. I would have an index card here. If I couldn't name all four of these and what they are, I would write them down right now on an index card. And next time I come to a question like this, I'll be able to say, what 6 things I know about this?
So Ms. Loach, that would be, you say it was radiation, conduction, and what did you call the other two?
Convection and evaporation.
So what are they? Conduction, convection. And you guys should know these. Did you read this chapter?
Yeah.
Okay. So here's the thing. I want you to rely on yourself. You've got to get into these chapters. This is basic content in the chapter. Heat loss, right? Again, if you read through this chapter, it's going to talk a lot about 1, adaptation to external life, right? 2, how that baby is going to adapt within that first hour is the most crucial time. And then over the next 6 to 10 hours, how is their body going to adapt? And then going on as the nurse, how are you going to take care of them? So important things to know here, because when you bring that baby out from mom, the first thing you got to do is what? After you made sure the baby's physiologically okay.
You gotta wrap them up.
Dry them off and put them skin to skin, right? That's what we do now, right?
Yeah.
Okay. So now you already know the answer to this question. One of you already said it, but it's not just knowing the answer. It's knowing why the other ones aren't the answer. So would turning on the overhead radiate warmer, would that prevent heat loss by evaporation?
No.
Why not?
Is that radiation?
Okay, it's radiation. Why wouldn't it prevent the evaporation?
Because the baby's still wet, so this, you have the fluid, putting heat over the baby has nothing to do with the fluid on the body.
Well, it actually might make the body, the water leave the body faster, right? If we put a heat on it.
Yeah.
You already said drying the baby with a warm blanket. What about closing the doors to the room? What does that encompass?
Convection,
Okay, and what about one?
conduction,
Now, once I've gone through those things and I've thought about that, I'm going to go here in my rationale. I'm not going to write the whole rationale because rationale only applies to that question. But is there anything that I didn't mention that I might want to add to my flashcard here that might help me answer more questions? So anything in there that could have helped you that you didn't know previously that might help you answer more questions, use it. This is your Saunders book, by the way. And you can't just go in under content. You got to go in under health problems to get to some of these questions. All right, let's go to the slides for a minute and we're going to talk a little bit. All right, so oxygen is the most important factor in controlling closure of the ductus arteriosus. True or false? What is the ductus arteriosus? Still waiting on an answer. Anybody can answer that.
Can you repeat the question?
What is the ductus arteriosus?
That is the artery that connects the pulmonary artery to the artery. I know it's A and A, so it's
Okay, aorta to the
aorta and the
aorta,
pulmonary
good.
artery. Yeah, aorta and the pulmonary artery. It's AA. I know that.
Okay, so it connects that pulmonary artery to the aorta, and that allows the blood to bypass the lungs, basically, right?
Yep.
Okay. So what causes this to close once the baby's born?
The foramen ovale or something like that. I'm probably not saying it right, but
Okay, is that what everybody else believes?
Pressure.
Pressure. Okay. What else? So what really happens when the baby's born? The cord's clamped, right? Baby takes the first breath. The lungs start to kick in. But why? All right, so the foramen ovale is going to close. We're going to have a decrease in that pulmonary vascular resistance and a decrease in the pressure in the right side of the heart. Once we clamp that cord, pressure within the whole system will increase. That will eventually lead to an increase in left-sided heart pressure. So now we're not going to need the ductus arteriosus, the ductus venosus, or those umbilical vessels. They're going to eventually become ligaments that don't even have a function. The foramen ovale allowed most of the oxygenated blood to enter that right atrium from the inferior vena cava and pass into the left atrium of the heart. So when the baby takes that first breath, it's going to push air into those lungs, and that's going to trigger that increase in that blood flow to the lungs and lung venous flow back to the left side of the heart. The pressure in the left atrium will become extremely high, higher than that in the right side. And that increased left atrial pressure causes the foramen ovale to close and allows output from the right ventricle to flow entirely into those lungs. All right, so now we're separating the oxygenated blood from the deoxygenated blood. The foramen ovale normally closes functionally at birth when that left atrial pressure increases and the right atrial pressure decreases. So is one true or false? All right, one is true. You guys should know this. Come on, you guys got to participate. If you don't participate, there's no point in doing this.
Are
We
you
can't
sharing?
see.
We can't see the slides.
Okay, well then say that, please. So here's the question. Can you see it now?
Yes.
All right, is oxygen the most important factor in closing the ductus arteriosus? Has anybody read this chapter? Are you scared to answer? What? I mean, it's true or false. Is it true or false?
It's true.
True.
Okay, it's true. Page 579. Oxygen is the most important factor in controlling its closure. Closure depends on the high oxygen content of the aortic blood resulting from that air entering the lungs at birth. The umbilical cords disappear at birth. I mean, the umbilical vessels disappear after birth. True or false?
False.
False.
What happens to them?
It turned to a ligament.
Okay, a non-functioning one, right?
Correct.
Respiratory rate of the infant is 15 to 30 per minute at birth.
I want to say false.
Okay, what is it?
30 to
30 to
60.
60.
30 to 60, good. A newborn experiencing heat loss can develop cold stress. True or false?
True.
True.
A finger stick blood sample is used to assess a newborn's blood glucose level.
False.
False.
False. Okay. So oxygen is the most important factor controlling the closure of the ductus arteriosus. It depends on that high oxygen content in the aortic blood from taking in that first breath. The resistance to the lungs will decrease at birth, and that allows more blood flow to the lungs, and that will also help oxygen exchange in those lungs. The ductus arteriosus, the veniosus, and the vessels that were vital during fetal life are no longer needed. After respirations are established in the newborn, they're going to be shallow, irregular, ranging from 30 to 60 a minute with short periods of apnea, usually less than 15 seconds. And newborns can experience heat loss through all four mechanisms, ultimately resulting in cold stress.
Mom, get those bumpers and plug them up.
Excuse me. Just go on mute, please, if you're going to talk, because I am recording. Newborns can experience heat loss through all four mechanisms, ultimately resulting in cold stress. Cold stress is excessive heat loss that requires the baby to use compensatory mechanisms such as non-shivering thermogenesis and tachypnea. How do babies control their heat? when they want to maintain that core body temperature. How do they maintain it?
Is it by shivering?
No, they don't shiver. That's the problem, right?
Oh, right.
So what is the main mechanism that they use to control their body temperature?
Is it energy, oxygen?
Isn't it thermogenesis with that brown fat and flexion? And where would we stick the baby when we want to get a blood sugar?
The hill?
On the
foot.
heel.
Okay, so the glucose levels on the newborn are typically drawn from the heel. Initially, that baby's glucose levels are going to decline when they're born. Why?
Because it was receiving the glucose from the mother.
Okay, through that placenta, and now there's no more placenta, right? So hypoglycemia, a very common problem, especially in the first couple days until that liver starts to mature a little bit and is able to regulate. So how can we counteract that? What's the best way?
By feeding them.
Feeding them, early breast or bottle feeding. All right, what period is defined as the first 28 days of life?
Neonatal.
Neonatal, and we
Neonatal.
have a lot of rapid, dramatic physiological changes going on here. You have to be aware of them. The red blood cells of a newborn have a lifespan of 82
100 days.
100 days compared to the 120 of that in an adult. Hypercapnia, hypoxia, and blank resulting from normal labor become the stimuli to initiate respirations in the newborn.
Acidosis.
Acidosis, good. Okay, so typically birth is a hypoxic experience, and really this is what's going to stimulate things in that baby. Blank involves the transfer of heat from one object to another when the two are in direct contact with each other.
Conduction.
Conduction, and this is why we put the blanket on the scale or something in between the baby and that cold item. The balance between heat loss and heat production is deemed what?
Thermoregulation.
Thermoregulation.
Thank you.
Thermoregulation, good. Thermoregulation. All right, so some areas that we're going to see some dramatic changes right after birth within the first 6 to 10 hours, the respiratory gas exchange along with circulation modifications are going to help that baby sustain life. So we're going to see changes in 4 interdependent areas: circulation, respiratory, thermoregulation, and the baby's ability to stabilize their own blood glucose. We have to have successful transition in each one of these areas. If we don't, there's going to be a problem. So that first hour is that golden hour of life. That's when that baby is transitioning from intrauterine to extrauterine, and it's a dramatic, critical time for that baby. The baby's considered at term between 38 and 42 weeks. Successful transition would require an increase in blood flow to the lungs, removal of the placenta, closure of the foramen ovale, the ductus venous, and the ductus arteriosus. Now, what else is going to happen during this period that's going to make this transition occur?
Say that.
What else is going to happen during this time that's going to help this transition occur? What's going to make these physiological, what is really most responsible for these physiological changes? What are some of the things that are going to happen? Just say anything that comes to your mind here, if you've read the chapter, okay? And we're going to talk about it, but I just want to hear what you know. What else is happening in that body? What's going to cause that heart rate to be stimulated, that output, the contractility? What's going to cause the lungs to empty out that fluid? What's going on? What's going to help that baby deal with that initial period of cold stress? Because remember, there's going to be a big change when they come from inside to outside, right? Imagine I got you in a hot tub, okay, and it's the middle of winter. You're outside in the hot tub. You're great while you're in the water. What happens as soon as I take you out into that air?
You
Gonna
get
freeze.
cold.
It's going to be a shock to your body, right? So what happens when our body experiences shock? What happens if I'm walking down the road and a big bear comes out?
Go into fight or flight.
Okay, so it's a similar sort of thing. They're not really going into fight or flight, but we are going to see, starting towards the end of pregnancy, increases in cortisol levels. Cortisol has a lot to do with this first stage of the baby's life. Okay, so what we're going to see here is increased levels of epinephrine and norepinephrine, and they're going to stimulate that cardiac output and the ability of the heart to contract. Surfactant will be released. The sodium pump is going to kick in, and that's going to help promote the clearance of that fluid from the lungs. What else is going to get rid of that fluid? Why can't babies who have a C-section get rid of it?
That's the pressure when
The
They
pressure
don't
from
get
the birth
that
canal?
squeeze on the lungs, right?
Correct, from the birth canal when they come out.
Okay. So physical forces of contractions during labor and birth, that asphyxia we just talked about, the hypoxia, the acidosis, the increased intracranial pressure from the cord itself being compressed and from the uterine contractions, and the cold stress experienced from the baby right after birth will cause the release of those catecholamines, epinephrine and norepinephrine. This is critical for changes involved in the transition to extrauterine life. So glucocorticoids, cortisol, and corticosterone all have a unique function in the baby, and they produce a wide range of enzymes before birth that will have little or no functioning during the baby's life, while they're in that fetal life. But once the baby's born, these all will affect the baby's ability to survive. So the baby loses that placenta at birth, and initially they'll be deprived of that source of oxygen. Glucose and heat also have other alternatives because they have to be immediately available for survival for this child. So if we're not able to provide these things, it could affect the baby's ability to survive. The lungs mature structurally and functionally, and they can handle the high stress or the high surface tension when that air starts to enter the alveoli with the first breath. So if the baby's immature, if they're born in the wrong gestational age, it can affect the ability of the lungs to do that, right? If the placenta's in poor health, it can affect the transfer of certain things. It can affect oxygenation. If mom has any sort of infections or poor health, it can affect the way that baby's going to transition. And this can also be included if mom has any issues with her own major organs, or the baby has problems with any of their major organs, any physical defects or anomalies. In the liver, glycogen will start to accumulate. Glucogenesis is initiated to meet the demands for glucose until feeding begins. However, remember that at birth, initially that liver is going to be a little bit immature, so it's going to take it a little time for this process to start. So things that we need for the baby to be able to transition are clearance of the fetal lung fluid, the ability of that surfactant to be secreted and breathing, transition of fetal to neonatal circulation. So it has to go from bypassing the lung to going back into that regular adult circulation that we have. Decreases in the pulmonary vascular resistance and increases in the pulmonary blood flow will occur. So that's just saying that we're not going to have as much resistance in the lungs. And so we'll see an increase in blood flow to those lungs. And then endocrine support of the transition. So when we talk about endocrine support, this is some of the things we just talked about. We're going to have that cortisol. That is the major regulatory hormone for maturation of the fetus and for adaptation of that baby at birth. The cortisol levels will progressively increase through the pregnancy, especially in the last few weeks. The cortisol will increase during labor, and that increase in the baby's cortisol level throughout the late gestation will support those physiological changes that helps the baby to adapt. For example, over the final weeks in pregnancy, again, we see increases in those catecholamines, which are what? Epinephrine and norepinephrine. And this helps with liver maturity, the baby's ability to digest things, heart and lung function, the surfactant in the lungs, the cortisol in association with increasing thyroid hormones, T3 and T4 activate that sodium pump to clear the lungs of that fluid. And also the changes, of course, that the baby goes through as it's being squeezed through that birth canal. That also helps remove that fluid in the lungs. There's one other thing that helps remove that fluid in the lungs. What is it? The lymph system. All right, so you should know about that. You'll probably read about that if you haven't already when you talk about transient tachypnea. All right, so the normal increase in cortisol would support the transition after birth. And that should be in that chapter 17 in box 2, I believe. All right, C-section without labor would blunt the rise in cortisol for the infant after birth. That's partially because of the unresponsiveness and the immaturity of the adrenal glands. If mom has a stressful delivery, it could show us that either mom or the baby has some sort of, that the baby has some sort of functional adrenal insufficiency, because we wouldn't see those rises that we would expect to see. So, if the baby were born with like Addison's disease or something like that, we might see a problem with those cortisol levels. The preterm infant may also have low cortisol levels around birth. If that was the case, we might see low blood pressures that are responsive to the cortisol treatment. If mom developed something like chorioamnionitis, which is what? Infection of that amniotic fluid, okay, that could cause the cortisol levels to go higher. So cortisol in association with increasing thyroid hormones will activate, remember I said T3 and T4 are going to help activate that sodium pump to help clear the lungs at birth, getting rid of that fluid. Those cortisol changes are a progressive process as the body prepares for birth. the cortisol levels will rise and then peak right after delivery. This is in the baby, okay? The normal increase in cortisol promotes and supports that transition after birth. So remember epinephrine, norepinephrine being released, that's going to help stimulate the heart, stimulate other things in the body, which I'm going to show you another slide on that in a minute. With the C-section, without labor, again, that's going to affect the cortisol level. Okay, so the baby's cortisol level may not rise after birth the way it would if they are either pretermed or if they have a C-section. Some effects of cortisol that help contribute to a normal birth or lung maturation. So it helps with the release of that surfactant. And surfactant does what? What's the purpose of it?
I can't remember exactly. Something with the alveoli in the lungs.
So it helps to, for the alveoli to work,
Open.
but it also gives us a bigger surface area for breathing. So it gives us more availability to that lung tissue and that alveoli to be able to breathe.
Does it also like help keep the shape of the alveoli, keep it open?
It keeps it open, yes. It helps to clear the lung fluid, the cortisol. It helps increase the B receptor density. It helps with the function of the gut, the thyroid axis. It helps regulate those catecholamines, and it helps control energy and metabolism. All right, so some differences that you'll see in the respiratory system, and you have to be aware of these. All right, because this is what is causing those changes. So after birth, the lungs now become the site of the gas exchange. We have a lower resistance going into the lungs, so more blood flow is able to go into those lungs, and we have that separation of oxygenated and deoxygenated blood. That increased oxygen in the lungs is going to help close that ductus arteriosus. We're going to have a greater pressure in the left side of the heart. Before birth, it's in the right side. After birth, that pressure increases now in the left side, and that causes that foramen ovale to close. Before, that ductus venosus was helping us bypass. Now that's going to close, and our hepatic portal circulation within that liver is going to begin. And then our body temperature is now going to be maintained through a flex position and that brown fat, a process called non-shivering thermogenesis. So the physical forces of mom's contractions can also lead to increased levels of the catecholamines. So contractions, the asphyxia, the increased pressure due to the cord compression and the contractions, and the cold environment. What structures in fetal circulation play a role in shunting blood away from the lungs?
The ductus arteriosus.
So you're saying A as in apple? Yes?
Yeah.
Stop being nervous, guys. Come on, let's talk. Let's learn it. If you don't talk about it, you're not going to learn it. I promise you that.
D as in dog.
Okay, D as in dog. Anything else?
I want to say B as in boy.
That's okay. You know, I appreciate the fact that you're trying, because if you don't try, you're not going to learn it. You can't sit around and wait on somebody else to show you the answers. You got to do this on your own. It's a lot of material, and if you don't do it, you're not going to learn it. You got to know this. You're going to have to know this for the exam. All right, so answers here are A and D. The ductus arteriosus and the foramen ovale are the structures that help bypass or shunt away from the lungs. They seal off and become non-functional at birth. The ductus venus plays a role with shunting blood from the liver, not the lungs. Select the structures in fetal circulation that play a role with shunting blood away from the lungs and the liver.
Is it the umbilical artery?
So what's the umbilical artery do? And if you don't know, look it up right now. There's no shame in that.
It brings the, I don't know, it brings the deoxygenated blood back to the placenta.
Does it shunt blood away from the lungs and the liver?
I don't think so.
Down to the placenta, and the fetal circulation.
No, we just said the ones that shunt it from the lungs.
Right, that's, well, the ductus venus away from the liver.
C
So
and
C
A.
Okay. And then we picked an answer there that was wrong because it shunted it from the liver.
B, C, and A.
Okay, so ductus venus from the liver, foramen ovale, and arteriosus from the lungs. Which statement below accurately describes the role of the ductus arteriosus?
Is it D as in dog? No.
No, but good try.
I think it's A, right? Arterial, like A and B.
Okay, does it connect the umbilical cord to umbilical artery to the inferior vena cava? Somebody gave me this answer in the beginning of class. What does the ductus arteriosus connect?
The pulmonary artery to the aorta. C.
Correct. Okay, the only correct statement is C. The structure connects the pulmonary artery to the aorta, to carry the mixed blood, oxygen and deoxygenated blood to the lower part of the body back to the placenta through the umbilical arteries. The blank carries oxygenated blood from the placenta to the fetus. Which answer is true for that?
The vein.
Okay, the umbilical vein carries the oxygenated blood from the placenta to the fetus. Some of the blood flow from this structure is shunted from
The liver.
okay, to the
Inferior vena cava, and then the ductus arteriosus.
Yep, to the inferior vena cava and then the ductus venus. So that's B here. Okay, the umbilical vein carries the oxygenated blood from the placenta to the fetus. Some of the blood flow from this structure is then shunted from the liver to the inferior vena cava by the ductus venus. The pressure in the fetal lungs before birth is blank, which allows blood from the blank to shunt to the blank via the blank. So, first of all, pressure in the fetal lungs before birth, high or low?
Would that be low?
Remember, it's high because remember, after birth, what happens? That resistance decreases, right? To allow more flow to the lungs.
Right.
Now, how does that flow move across? What takes it, first of all? What shunts it? We know it's not the ductus venus, right? Because that shunts blood from where?
Liver.
Okay, so we can eliminate that, right?
Right. So it is A and
And
an
we
apple.
can eliminate anything with low because we know the pressure is high in the lungs, right? This is where that brainstorming comes in, guys. If you could brainstorm on this stuff and remember it, it'll be easier to remember. So you're going to eliminate anything with low pressure here because the pressure is going to be high. And you're going to eliminate anything that says that's associated with shunting from the liver, which is going to be your ductus venus. All right, so the answer here is going to be what?
A.
All right, so pressure in the fetal lungs is high, which allows the blood from the pulmonary artery to shunt into the aorta by that ductus arteriosus. After the birth of the baby, heart circulation changes to the closure of the shunting structure in the baby's circulatory system. Select below all the reasons for the closure of these shunting structures.
Would be A as an apple.
Okay, is that the only one? Says all the reasons. So after birth, we're talking about, right?
Mm-hmm.
What's happening with the lung resistance? Increases or decreases? We just said before birth, it's what? Low or high?
High.
And after birth, it has to do what?
Low.
It has to decrease, right? Because if the resistance is too high, the blood can't go into the lungs, right? If we decrease the resistance, more blood flow will go into the lungs, which is what we need after birth because we're no longer bypassing the lungs, right? And how's our oxygen level going to be after birth? Should it be higher or lower? Higher or lower, guys?
Would it be
I think
lower?
it's a little low.
Okay, what's going to cause the ductus arteriosus to close?
The clamping of the
Us.
cord and then we decrease.
The high level of oxygen, remember?
Correct.
So pressure in the right side of the heart will be lower now because it's going to be higher in the left side of the heart, which is going to close the Foramen ovale, right?
Yes.
Resistance in the lungs will decrease, allowing blood flow into the lungs, assisting with what? Increases in oxygen level, which is going to help with closure of that ductus arteriosus, right?
Right.
Will remove or decrease the production of prostaglandin. Because that prostaglandin actually helps keep that ductus arteriosus open during fetal circulation. So after birth, prostaglandin is going to decrease. That's going to help with closing that ductus arteriosus. That prostaglandin was previously being produced by the placenta. So when the placenta comes out, that's going to decrease. Got it?
Got it.
The right ventricle pumps what type of blood up through the pulmonary artery?
Deoxygenated.
So this is really before what?
This before birth? Oh,
Okay, so we're going to have that mixture of blood, right? After birth, it's separated. All right, so what kind of changes are we going to see with the cardiac system? We're going to switch from fetal to newborn circulation. We'll change from gas exchange that happens now in the placenta during utero to external life gas exchange, which is going to occur in the lungs, right? Changes in those structures, the foramen ovale, the ductus arteriosus, the ductus venous, the umbilical arteries and vein. Immediate after birth, we'll see a heart rate of about 110 to 160. We expect that to change to about 120 to 130. The result of those changes can cause functional heart murmurs in that neonate. These functional cardiac murmurs may be heard during that period, and they're usually a result of those changing dynamics of that cardiovascular system at birth. And then they're benign. There's really no major issue with them. They'll usually go away, or the child will outgrow them. Once they stabilize, you may not hear them anymore. The blood volume would depend on the amount of blood that's transferred from the placenta at birth. And now we see different theories about delaying of the clamping of the cord. They believe that when we delay the clamping, that it allows more blood to transfer from the placenta to the baby, and that increasing the blood volume up to a third can help the child and give it a lot of benefits. The iron in the blood increases the infant's iron storage, and iron is essential for this baby's brain to develop. Tachycardia might be found if the baby has some sort of volume depletion issue, any sort of heart or respiratory disease, if they're facing some sort of drug withdrawal because mom was addicted, or if the baby has hyperthyroidism. Bradycardia would be associated with things like apnea, and it's usually seen in babies that are presenting with hypoxia. When we cut that umbilical cord at birth and the breath begins, the oxygen content in that blood will increase dramatically. that is a potent pulmonary vasodilator. And so those lung vessels will start to dilate. The resistance in those lungs will decrease. That's going to allow more blood flow through the lungs, increasing that venous blood flow to the baby's left atrium, resulting in a higher pressure in that left atrium. Remember, that's what closes that foramen ovale. Oxygen is also a potent constrictor of the ductus arteriosus. So with the baby's first breath, it slowly starts to close, and that stops that blood from shunting from the pulmonary artery into the aorta and puts it into regular systemic flow. That patent foramen ovale is really a hole in the wall that separates the heart's two upper chambers of the atria. All babies have that opening called a foramen ovale before birth, and it allows the blood to bypass the lungs. After birth, that tissue will grow back together and the hole will close. And what causes that? What causes that closure? What causes that foramen ovale to close?
The left atrial pressure.
Right, that increased pressure switching now from the right side of the heart to the left side of the heart. So the blood goes to the left side of the baby's heart and provides oxygen to the baby's brain. After birth, the foramen ovale closes. That happens when the baby starts to breathe and blood flows to the lungs to get oxygen. The blood enters the left side of the baby's heart before it gets pumped to the rest of the body. The ductus arteriosus connects that pulmonary artery to that aorta. All right, it's normal and essential. That becomes abnormal if it remains open after the neonatal period. So it really is starting to close right at birth. You know, books will say different things. Some will say it'll close within a few hours, and some say it takes a few days. It really just depends on the individual child. It's going to functionally close, and that closure depends on what? It's right there on the screen for you.
I'm about to say oxygen level.
All right, so we also have the ductus venus. That's short. That shunts that blood from the left umbilical vein directly into the inferior vena cava, allowing the oxygenated blood from the placenta to bypass the liver. It closes a few days after the birth. Remember, right after birth, the liver's a little immature still, but it will start to gradually fully function, and then the ductus venus won't be needed anymore, so it's going to turn into a ligament. I know I'm beating this into your brain. You need to know it, okay? The foramen ovale is going to close with that decreased pulmonary or blood flow to the lung. So we're going to get increased blood flow to the lung because of that decreased lung resistance. Less resistance allows more blood flow. That also will increase pressure to the left side of that heart. The ductus arteriosus is going to close due to the increase of oxygen to the lungs. The ductus venus will close and the liver will start to function. It's the clamping of the cord, by the way, that increases that left-sided heart pressure. So here we go. Umbilical cord is clamped. Respirations begin. We see an increase of oxygenation in the lungs and a decrease in resistance to those lungs. Increased blood flow to the lungs. Increased pressure to the left atrium. The right atrium will have a decrease in pressure. but it's really the increase in that pressure in the left atrium that closes that foramen ovale. Increased oxygen levels will increase systemic vascular resistance. We'll see a decrease in the vena cava return. This reduces blood flow in that umbilical vein and makes it become a ligament. The ductus venus will close. Once that closes, we'll have circulation back to our what? Come on, what's the ductus venus bypass? What does the ductus venus shunt the blood away from?
Liver.
The liver. Okay. So if this ductus venus closes, that means hepatic portal circulation and liver function is going to kick in. We'll see increased pressure in the aorta and the ductus arteriosus closes. All right, so again, because of the changing dynamics of that cardiovascular system, we may see some of those cardiac murmurs that are usually benign. And those arise from the turbulent blood flow that's occurring around that heart. With volume depletion, cardiac lung disease, drug withdrawal, and hyperthyroidism, we would see tachycardia. With apnea and hypoxia, we would see bradycardia. And then the blood volume would depend on the amount of blood that's transferred from the placenta, usually around 80 to 100 mLs. The volume can change as much as 25 to 40%, depending on how early they clamp the cord. All right, so early would be considered before 30 or 40 seconds, and late clamping or delayed clamping would be considered after 3 minutes. Again, recent studies show that delayed cord clamping improved the baby's cardiopulmonary adaptation, the prevention of iron deficiency anemia, increases in blood pressure, increased iron stores. Remember, iron stores come from mom, right? And that occurs when? When does mom transfer the iron to the baby?
Last trimester.
Okay, so this is why babies that are born what have a problem with their iron storage.
Premature.
Premature, because they don't always get that full transfer of certain things. All right, so other things, what we would see: improving oxygenation and transport and increasing red blood cells. All these we would see from that cord clamping, that delay in the cord clamping. How will our white blood cells be? Expect somebody to notice. How are those white blood cells going to be? What happens during the labor process?
Will it be high?
Okay, up for mom, right? How about for the baby? So hemoglobin levels higher in newborns within the first few hours. They peak between 4 and 6 and then decrease over the next 12 to 18. White blood cells, as a result of birth trauma, elevated. The red blood cells are going to be larger in size when we compare them to an adult. They have the ability to carry a little bit more oxygen. However, once the baby's born, the red blood cell count will then start to gradually increase as the cells start to decrease in size. So during utero, the red blood cells are going to be a little bit larger, but not as many. After birth, they size will decrease and they'll become more abundant. And that's because they now live in in a body with a much higher oxygen concentrate. The red blood cells have a lifespan of 80 to 100 compared to that in an adult with 120. So here's some of the normal values that you might see. These labs are a little bit off. So let me tell you what your book says. Your book says hemoglobin 16 to 18, hematocrit 46 to 68, platelets 150 to 350, red blood cells 4.5 to 7.0, and white blood cells 10 to 30,000. So that was the only thing on there that was equivalent to what your book says. We talked about the delayed cord clamping, what it improves, how it helps the baby. All right, so it's going to improve the baby's ability to adapt cardiovascular wise. It helps prevent anemia, helps increase the blood pressure, helps improve the ability of the body to transport that oxygen, helps increase the red blood cell flow, and it should be the method of choice if possible. All right, so respiratory wise, we have this initiation of respirations. The baby's adjusting from this fluid-filled environment to a gaseous one now. Surfactant will help prevent those alveolus with the shape, like you said, preventing them from collapsing, and it provides a bigger area of surface for these things to occur in the body. Respirations would be 30 to 60, irregular, shallow, unlabored, short periods of apnea. They should be less than 15 seconds. Anything greater than 15 seconds should be of concern. And then you want to make sure that the chest is rising and falling symmetrically. How do babies breathe? Through their mouth or through their nose?
No.
No.
Nose. Okay, good. So immediate adaptations that we'll see right at birth are the first big breath, their cry. All right, that's a reflex. Then we might see signs of distress if the fluid is removed too slowly or incompetently, and something called transient tachypnea. All right, where the respirations are greater than 60. This happens a lot with C-section patients, again, because the babies don't get that squeeze. The surfactant, we already said that should be increasing. And then when you're looking at the baby, you're looking for signs and symptoms of respiratory distress. So what kind of signs would you look for? So you're making sure that the lungs are expanding equally bilaterally. You're looking within the clavicle, the ribs, and you're looking for any sort of retractions. You guys are familiar with those, right? Nurses? Everybody knows
Yes.
what retractions look like?
Yes.
Okay. You can expect to hear crackles during the first 30 minutes to an hour. Why? What are crackles?
Fluid.
The fluid.
Fluid. And like I said, you're going to get some of that fluid's going to be removed because of that sodium pump being activated by the cortisol and the epinephrine and norepinephrine. Some of that fluid is going to be removed from the squeeze going through the vaginal cage. And then some of it is, I mean, the channel, not the cage. And then some of it's going to be removed because of what's the third thing I said was going to help remove it. What helps absorb some of that fluid?
Lymphatic system.
The lymphatic system. Good. So we need to see that initiation of the respiratory movement. So that symmetrical movement of the lungs, that deep breath, the expansion of the lungs. Eventually, the baby will develop some sort of functional residual capacity, increase pulmonary blood flow. So the blood flow to the lungs is going to increase and cardiac output is going to change now because we've been bypassing certain things. Is the following statement true or false? A respiratory rate of 44 breaths per minute would be considered normal in the newborn.
True.
Okay, good. So what kind of things might we see with these babies? Risk for ineffective thermoregulation related to the transition. And we talked about that, right? When they come out, it's going to be exposure to coldness. They use brown fat and flexion in order to maintain. But first thing we got to do really is get that fluid off of them and dump them onto mom skin to skin. That's going to help get them warm. You can still toss a blanket if it's necessary. But skin to skin is the best way to warm the baby. Unless the baby has some sort of issue, okay? Risk for ineffective airway clearance. Again, the baby could have mucus in the mouth. What else could present a problem for this baby? What could they swallow? Cause respiratory issue. The meconium, yes. And then risk for infection related to the newly clamped umbilical cord and exposure of the eyes to the vaginal secretions, meaning what? Why are we worried about the exposure of the eyes to the vaginal secretions?
Is it because of like sexually transmitted disease?
Yes. So that's why, you know, the states all have those laws that within an hour or so, you're going to do what with those eyes?
Erythromycin.
Okay, good. All right. So what kind of things put the baby at risk for heat loss? So how's the baby's skin at birth?
It's wet.
Okay, it's wet, but how is the skin itself? What is the, you know, like in normal
It's thin.
adults, how's our skin?
Oh yeah.
Their
It
skin
provides
is
us
thin.
protective quality because what? The protective layers that we develop, right? So just like the older adult loses those protective layers, the baby's not born with them. So their skin is going to be thin and their blood vessels are going to be closer to the surface. Okay, they're not going to be able to shiver. They use a process called non-shivering thermogenesis, which is about using the brown fat. And they have limited stores of glycogen and glucose. So when they go into this cold stress or they start to burn up this fat, they can easily become hypoglycemic because they're also using up their available glucose. They have limited use of their voluntary muscles, but they are able to use a process called flexion, which helps them to stay warm. They have a large body surface area relative to their body weight. They lack the subcutaneous fat and the ability to conserve heat by changing postures. They also can't get up and get their own blanket or adjust the temperature. And they can't tell you that they're cold or hot, because a lot of people overdress their kids too, okay? Kid will be in the house, it's 90 degrees in the house, they got 17 blankets on them, and then they take that kid who's all sweaty and cold right out into the air. So this brown adipose fat, or the brown fat, is due to a large blood supply. All right, one of two types of fat or adipose tissue. The other one being white adipose tissue or white fat, which is found in mammals. It's really abundant in newborns and in hibernating mammals, and its primary function is help generate body heat in animals or newborns that don't have that ability to shiver. It's found between the scapula, the axilla, the nape of the neck, and the mediastinum. Really, they could check for this before the baby's born. So you need to know these. Conduction. This is when we transfer heat from the object to object. So this is going to be like the scale. They put the mattress on here, or I put the mattress on here. Really, the scale is the one I like to use because that's what we put the baby on most. So we always put the blanket on the scale, then we zero the scale out, right? And then we put the baby on the scale on top of the blanket, because we have to weigh the baby naked in order to get the accurate rate. Convection, that's a flow of heat from a body surface to a cooler surrounding. So this could happen like if you open a door and you get this flow of air. Evaporation, this is loss of heat when the liquid is converted into a vapor. So this is why we have to be super cautious, one, with the amniotic fluid on the baby, drying it off immediately before we lay it on mom, and then bathing. And then radiation, which is the loss of body heat to a cooler solid surface. So this would be like from a radiator, a wall, a cold wall. So interventions like for conduction, make sure you warm your hands, the scale, the stethoscope, anything that could transfer that coldness. For convection, avoid drafts. Use warmed blankets and isolates. For evaporation, make sure you dry the baby thoroughly, cover its head. And then radiation, we're keeping the crib away from the cold walls and the windows. Just a little picture to help sink it in. So what really happens to the baby when they're having this hypothermic experience? What's going to happen overall? Anybody want to tell me? What y'all know about it?
So they become hypoglycemic because they're using up the fat that they have, the brown fats, which causes them to use up whatever energy they have, and they become in distress, right?
Okay, so they have this hypothermia, and that's going to increase the body's metabolism, right? Because the body's going to try to do some sort of thing to stop it from being cold, right? So homeostasis here, right? So what happens is the baby's metabolism increases, which is also going to do what as far as the overall body? So the baby's primary method of heat production is this non-shivering thermogenesis, okay? So the brown fat is oxidized in response to the cold exposure. This is a really high vascular fat, all right? And it's unique because it's able to convert energy directly into heat when it's activated by the baby's sympathetic nervous system. So what happens is when the baby starts to get cold, all right, the sympathetic nervous system will kick in and it will start to release those catecholamines. That brown fat makes up about 6% of the weight in the newborn. So when the baby experiences the cold environment, the norepinephrine is released. That will stimulate the brown fat metabolism and start to break down triglycerides. That's going to increase cardiac output. It will increase blood flow through that brown fat. The blood will start to warm up because of the increase in the metabolism and the activity of that brown fat. Now, in cold stress, we have an excessive amount of heat loss. So the baby starts to use compensatory measures like non-shivering thermogenesis and tachypnea, which is what? An increase in those respirations, right? They're doing this trying to maintain the body temperature. As the body temperature starts to decrease, the baby will become less active, lethargic, hypotonic, and weaker. If we don't resolve the cold stress, it depletes the brown fat, it increases the oxygen and the glucose consumption, leads to respiratory distress, depletion of the glycogen. That causes hypoglycemia, vasoconstriction of the lungs, metabolic acidosis, jaundice, hypoxia, and decreased surfactant production. So we prevent this by maintaining normal temperatures. Using things like pre-warming blankets and hats to prevent heat loss through conduction. Keeping the baby's isolate fully charged and heated all the time. Drying that baby right after birth. Using that skin-to-skin contact if the baby's stable. Promoting early breastfeeding to give the baby fuel for that non-shivering thermogenesis. Using heated or humidified oxygen if needed. Using that radiant warmer.
I can start right here. I got two hands.
Excuse me. Hold on a second, guys. Let me put whoever's talking on mute. Using that heat and humidified oxygen, using the radiant warmer or the double wall isolate to prevent loss of heat from radiation. No bathing until the baby's medically stable, and use a radiant heat source while you're bathing. Avoid placing the skin temperature probe over any bony area or an area with brown fat, because it does not give you an accurate assessment of the body temperature. All right, most temperature probes would be placed over the liver when the baby's supine or sideline. You might see that on a test question, I would know it. All right, so that thermoregulation is the balance between the heat loss and the production. Again, that production is primarily through the non-shivering, thermogenesis, and tachypnea. We talked about those 4 mechanisms that lead to cold stress. We need a neutral environment, all right, neutral thermal environment. So we're maintaining the temperature without increasing the metabolic rate. Babies can easily become overheated too. All right, and that's because they have a large body surface, a limited amount of insulation. They don't have a full ability to sweat. And because their regulation of the body is done through that thermogeneration and through a negative feedback system that tries to create a balance between heat production, heat gain, and heat loss. So the primary regulator for heat is the hypothalamus and the central nervous system, which the central nervous system is going to be a little immature in even a full-term baby. And again, that's one of the reasons why they can become easily overheated. So we don't want to leave them in the sun too long, put them next to anything too warm. If we do overheat them, it could precipitate them to dehydration because of risk for fluid loss. If the baby was overheated, it could present some sort of respiratory distress, or you might see an increase in that respiratory rate. And you'll also see likely an increase in the metabolic activity. So again, these are some of the things we just talked about ways to keep the baby warm. Where's that temperature probe going to go?
Over the liver.
Okay. So iron storage, red blood cells are destroyed and iron is released and stored by the liver for the new red blood cells. With the need for fewer red blood cells, the heme and the hemoglobin is sometimes converted to bilirubin. So this is what sometimes leads them to developing jaundice. All right, now if the bilirubin's unconjugated, it's fat soluble. So then it's processed into conjugated or direct bilirubin, which is water soluble and then is excreted by the feces and the kidneys. If the liver can't break it down and excrete it, then the baby can develop jaundice. So carbohydrate metabolism, the baby has to also adapt to their own metabolism. The blood sugar is usually 70 to 80% of the moms. Usually if the blood sugar is under 40, we're worrying. Glucose is the main source of energy, and you might even see 35 in your book. So sometimes between 35 and 40, depending on what's going on with the baby, how we're going to treat it. What's the initial step to treat this?
Breastfeeding or early feeding.
Yeah, early feeding. All right, bilirubin conjugation will usually produce 2 times as much as an adult. And the 3 groups of jaundice are based on the accumulation and the mechanism of that bilirubin itself. So what's the difference between physical and pathological jaundice? Who knows? Pathological is usually going to be seen within the first 24 hours. Physical doesn't occur for a few days. So pathological usually means there's something else going on. All right, so what are some of the causes? All right, so overproduction of the red blood cells, polycythemia, too many red blood cells. All right, so the blood's going to be really thick. ABO incompatibility, trauma, or drugs. And then decreased conjugation is caused by physiological jaundice, hypothyroidism. We can also have an impaired excretion of the conjugated bilirubin if there's some sort of obstruction in the biliary system that can lead to sepsis, or if the child has sepsis, because the sepsis, we don't see organ perfusion, right? Because the body's vasodilating, and so the blood coming from the heart doesn't get out and perfuse the way it's supposed to. Just want to take a look at my other notes and make sure there's nothing else I need to tell you about that right now. Just remember that the liver is not going to be fully functional at birth. It'll be slightly immature. It will probably take about 3 months before the liver becomes fully functional, right? And then functions for the liver include things like blood coagulation, iron storage, carbohydrate metabolism, and conjugating that bilirubin. Glycogen is also going to be stored in that liver, and it provides energy. It can become depleted if the metabolic needs of the newborn increase, like in any sort of cold or respiratory distress. During the first 24 to 48 hours of life, that's when you really got to watch those glucose levels, okay? That's going to happen more likely then. All right, so when the liver doesn't break down or excrete that bilirubin, it's going to lead to a buildup, and that's going to cause jaundice. Bilirubin itself is toxic. It has to be removed from the body, or it can cause major issues. If the baby does develop jaundice, then we'll get a yellowing of the skin, the sclera, and the mucous membranes. We'll also see increased bilirubin levels in the blood. This can develop or cause a baby to develop something called bilirubin encephalopathy. That can cause permanent brain damage. So we have to be careful. So again, causes are mixing of the baby and mom's blood in that Rh incompatibility, prematurity, some sort of asphyxia of birth, insufficient intake of milk during breastfeeding, or drugs, torch infections. There's a number of reasons why this can happen. So again, bilirubin overproduction, decreased bilirubin conjugation, that would be seen more in the physiological jaundice, in that hypothyroidism and breastfeeding. The inability of the body to excrete the bilirubin. So this could be caused by something called biliary atresia, gallstones, or some sort of tumor that the baby may have developed, or neoplasm, sepsis, hepatitis, or chromosome abnormalities could all lead to this type of jaundice with the impaired excretion. All right, GI, the newborn baby, the full term one, has the ability to be able to swallow, digest, and metabolize. But the pH in the stomach is going to be a little bit acidic. Once the gut starts to change, depending on what feeding is received, then the bowel sounds will go back to normal after birth, but they might be a little hypoactive the first day. Babies do have this mucosal barrier protection. Their stomach is much smaller. Okay, so we use small frequent feeding. So, you know, how much are we giving this baby at birth?
1 to 3 ounces.
Okay, so most of the time we're giving them 1 or 2 ounces, right? And then, you know, depending on the baby, whether it's premature, mature, you might be able to give up to 2 or 3. Guys, give me 1 second. I just got to take this phone call. I got a situation at the school, so just give me 1 second. I'm gonna pause. Okay, so we were talking about the baby having this protective barrier, okay, to prevent any sort of bacteria, toxins, and all that until the GI starts to develop colonization with bacteria, because the GI system does have some sort of bacteria in it, right, to prevent us from getting any problems. It helps fight things off. It helps get rid of certain things. So we do have a certain amount of bacteria in the gut, but babies aren't just born with it. Once they start to either drink the breast milk or the formula, then that helps to colonize the gut. And usually within about 24 hours, the baby can start to produce vitamin K. So before that, we're usually giving them a vitamin K injection. Part of that is to help with the gut, and part of it is to help with blood clotting. So breast milk itself provides a passive mechanism for the baby against a deficient intestinal defense system. It contains antibodies and leukocytes and other substances that interfere with the bacterial colonization and prevent harmful penetration of certain things. Other things that we'll see is the cardiac sphincter and the nervous control of the stomach is still immature. So that can cause some regurgitation in babies, especially if they overeat, and uncoordinated peristaltic activity. So we want to make sure that the baby's having proper weight gain. They should have approximately 108 kcals per kilogram per day from birth to about 6 months of age. We don't want to overfeed the baby, all right? And we have to be careful. Most of the time we're encouraging mom to burp the baby, because this helps to get rid of, one, the baby's chance of vomiting by eliminating some of that air, all right? And help with the digestive enzymes a little bit, all right? So most babies have digestive enzymes at birth. They are able to digest simple carbs and proteins, but not complex carbs. Also, they don't have much of an ability to break down fat, because remember that liver function is still not completely mature. And so part of that ability to break down fat comes from the liver, from the amylase and the lipase levels. Normally, a baby will lose about 5 to 10% of their birth weight within the first week, and that's okay. If it's more than that, then it's a problem. Whoop, let me go back, sorry. The meconium, that's the first stool, right? And then we have the transitional stool and then the milk stool. So you should be familiar with these. If they swallow the meconium, it can cause respiratory distress, sepsis, some other issues. Normally, our breastfed babies are going to have that yellow, gold, loose, stringy, pasty, sour smelling stool. And with formula, they'll have the loose, pasty, yellow green stool. Meconium is going to be black or dark green. Newborns that are fed early pass stools sooner, and that helps reduce the bilirubin buildup as well. So if we feed them early, we can eliminate some of that bilirubin and hopefully eliminate the risk for them developing jaundice. When assessing the stools of a 1-week-old newborn being breastfed, what would the nurse expect to find?
C.
Okay, good. Again, yellow, gold, loose, stringy, pasty, sour smelling. Greenish black would be meconium. Seedy, greenish brown stool would be transitional. And then yellow, soft form stool would be more likely with the formula. Kidney function. So the baby won't be able to concentrate urine fully until about 3 months of age. So they're going to have a low specific gravity. 6 to 8 times a day for urinating is normal. So when they ask you how many diapers, that's what you should be saying. If you're monitoring the baby's weight, how can we do that? Weight loss. Weigh those diapers, right? Whenever you're doing that, you got to remember that you got to weigh the diaper beforehand so that you have a tear on it. And then you would remove that from the scale and then weigh the diaper when it's wet. They'll have a low glomerular filtration rate. And so they don't have the same ability to excrete and conserve. Remember, that has to do with your fluid and electrolytes, because this is what your body's doing all day, removing what you don't need or selectively bringing back into the vascular system what you do need. So this is going to affect the baby's ability to excrete salt, water, and drugs. This means if the baby's on any sort of IV fluids, you have to be super cautious. Remember, a baby's body weight is about 90%. So big changes can occur with little changes in that baby's body. Your book says 75% as far as water, but you know, lifetime, traditionally, we've learned 90%. That kidney is not going to become fully mature, all right, for about 12 to 18 months. That's when that glomerular filtration rate will be really what is expected in someone. All right, what about immunity? The immune system starts to work in gestation, but some of the responses don't function in the early neonatal period. The baby is protected from some infections because of mom's antibodies that will circulate in their system until about 6 months. IgG will cross the placenta to the baby while in utero, and babies that are breastfed will receive antibodies if that include IgE, IgA, IgM, and IgG. Babies can easily acquire an infection because their immune system is immature and it doesn't have an immediate response. So it's going to take it a longer period of time to fight an infection. That environment, while they're in the uterus, protects the baby from most of those harmful microorganisms and the need for any sort of defensive system. But once they're born, all right, they'll be exposed to a lot more organisms, and they have to develop now a balance between the defense in their system, the hostile environment, and also that transition that is occurring for them from utero to the world. These babies won't start to begin to produce their own antibodies until they reach the age of 2 or 3 months. So the immune system itself has 3 purposes. It protects us from invading organisms. It provides homeostasis by eliminating our worn out host cells. And it surveys and looks for enemies and then removes them. The baby's immune response would involve recognizing the pathogen, followed by activation of these mechanisms to react against it and eliminate it. The immune response involves leukocytes, and the immune response can be divided into 2 categories: natural and acquired immunity. The mechanisms are interrelated and interdependent, and both are required for immunocompetency. So in order for our immune system to actually work. Natural immunity would include responses to physical barriers like intact skin and mucous membranes, chemical barriers like gastric acids, digestive enzymes, non-pathological organisms that would make up the baby's natural immune system. So natural immunity would involve killing the most basic microorganisms or bacteria by the use of these phagocytic cells. So with natural immunity, we have the most basic host defense response, and we use phagocytosis in that process. That's what the baby would be using. For the baby to have acquired immunity, it would have first had to have some sort of exposure. All right, so developing those circulating antibodies or immunoglobulins that help destroy, and they have to also develop the activated lymphocytes. Acquired immunity is absent until the baby has the first invasion by some sort of foreign organism or toxin, and then it develops that in response to that. Immunologic ability depends heavily on immunoglobulins, IgG, IgM, and IgA. The baby uses those three immunoglobulins for defense against microorganisms. But for the first several months, they'll remain very susceptible to any sort of infection. I really should still be on the previous page here. So that IgG is the major one. It's the most abundant. It makes about 80% of the circulating antibodies. It's in the serum and the interstitial fluid. It's the only one that's able to cross the placenta. That happens around 20 to 22 weeks gestation, and IgG will produce antibodies against bacteria, bacterial toxins, and viral agents. IgA is the second most abundant. It does not cross the placenta. It doesn't reach its maximum levels until childhood. It does help protect the mucous membranes from viruses and bacteria. IgA is mostly found in those GI tracts, respiratory tracts, tears, saliva, colostrum, and breast milk. All right, so the major source of IgA is where?
Breast milk?
Breast milk, high levels, okay? So that helps the baby's colonization of the gut as well. That's my mom, she won't be mad at me. IgM is found in the blood, the lymph fluid, and it's the first one to respond to infection. Guys, I better take it. She don't call me like this. Hello. All right, so the IgM is in the blood and the lymph fluid. It's the first immunoglobulin to respond to infection. Again, it doesn't cross the placenta because only IgG does that, right? It offers protection from bloodborne infections and antibodies that are formed during either some sort of intrauterine infection from mom or during a neonatal infection. All right, we talked about natural immunity and the barriers, the chemical barriers, the pathological organisms. In acquired immunity, you're going to develop these immunoglobulins. Again, they're absent until the first time that there's an invasion. The skin is a large organ and it makes up a great deal of the baby's body, okay? So it's sensitive, fragile, it'll have neutral pH on the skin and a higher water content. Because of these reasons, it's more vulnerable to injury and infections. So it's there to help provide that protective layer between the body and the environment. It does help limit some of the water loss, prevents absorption of certain agents, helps provide thermoregulation and fat storage, and protects the baby against physical trauma. The skin can vary in color based on the baby's age, race, or ethnic group, and temperature, and whether they're crying or not. This vernix caseosa, who's going to tell me about that? What is it? What's the purpose of it?
To protect the skin.
Okay, it protects the baby, right? It's like this oily, thick substance that develops on the baby's skin, right? Kind of looks like cheese. All right, and it protects the skin of the baby. It's formed by secretions from the baby's oil glands. And we don't remove it. It will be absorbed into the skin, okay? Neurological system, so we have a cephalocaudal and proximal distal pattern. What's that mean?
From head to toe.
Okay. Did I tell you guys enough about the skin? Are you okay with that before I go on?
Yes.
All right, so we have this cephalocaudal proximal distal pattern that the baby's developing in. Acute senses of hearing, smelling, taste. Baby's adapting to the respiratory, circulatory, thermoregulation, and the musculoskeletal system. And then the baby's going to have certain reflexes, which when we get to chapter 18, we'll talk about that more. Those reflexes are an indication of how the baby's developing neurologically. Nurse is assessing the sensory capabilities of a newborn. Which of the following is least mature at birth?
Vision. Vision.
Okay, good. Periods of reactivity, you definitely have to know this. Before we go on to that, let me just talk about those other things we were just talking about. Hearing well developed at birth. Taste, they should be able to distinguish between sweet and sour by 72 hours. Smell, they can distinguish between mom's breast milk and breast milk from others. And you can actually put them on your belly and they can smell that breast milk and they'll actually start to slide up the belly towards that milk. And then vision, incomplete at birth. Maturation dependent on nutrition. Visual stimulation, they only have the ability to focus on close objects, those that are 8 to 10 inches away. Visual acuity of 20 to 140. They can track objects in midline or beyond 90 inches. And it's least mature at birth. All right, reactivity period. So the first period of reactivity begins at birth. It can last for about 30 minutes to 2 hours. The baby's alert, moving, might appear hungry. They'll have myoclonic movements of the eyes, spontaneous motor reflexes, sucking motions, chewing, rooting, and the muscle tone and motor activity are increased during this time. Also, respiration and heart rate will start to elevate, but begin to slow as the next period kicks in. This period of alertness allows the parents to interact with the newborn and enjoy their new baby. And also at this time, babies might latch on the nipple as part of their first experience, and the parents are looking at the baby to see that they have all this normal stuff that they would want to see. The next period would be the period of decreased responsiveness. So between 30 and 120 minutes of age, the baby will enter that second stage, and that is the sleep period. We'll see a decrease in activity. This is called the period of decreased responsiveness. The baby's movements will be less jerky and less frequent. We'll see a decrease in the heart rate and the respiratory rate. The muscles start to relax. It's difficult now during this time to arouse or interact with the baby. The baby won't show any interest in sucking, and the baby and mom can now rest during this time. It's a good time for them to rest. Remember, birthing is a heavy-duty, energetic process. And then the second period of reactivity will occur between 2 and 8 hours in the newborn. So they start to show an interest again in that environmental stimuli. Heart and respiratory rate increases, peristalsis increases. The newborn may pass the meconium during that time or void. We'll see motor activity and muscle tone increase in conjunction with increases in muscular coordination. Interaction is encouraged between mom and the baby during the second period of reactivity. And it also provides a good opportunity for the parents to examine their newborn and ask questions. So during the second period of reactivity, that's the most opportune time to teach about feeding, positioning, and diaper changing. Is the following statement true or false? During the first period of reactivity, a newborn is quite sleepy.
False.
Okay, false. During the first period of reactivity, the newborn is alert and moving and may be hungry. So when is the baby going to be sleepy?
The second stage.
All right, in that decreased, right?
Yes.
Period of decreased responsiveness between 30 and 120 minutes of age. Some behavioral responses. So orientation, that's the baby's response to the stimuli. Habituation is the baby's ability to process and respond to sounds that they hear, things that they see. And the baby has the ability to block out external stimuli after it becomes used to the activity. They'll start to develop some motor maturity, and they should have the ability to do self-quieting behaviors like, they might suck on their fist or on their thumb. They also enjoy things like cuddling and snuggling. Now, if the baby's autistic, they do have specific ways that they can wrap the baby to prevent skin-to-skin contact. And you'll see these used overseas, like in places like Russia. Pretty cool. All right, so, think about what are some of the things that we talked about today. Everything we went over today, you need to know it. If you don't know it, if you weren't able to answer these questions, you need to go back and review it. I would have liked to have gotten to chapter 18 today, but